From the JAMA Network, this is JAMA's Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Welcome, JAMA Surgery listeners. This is Amalia Cochran, the web and social media editor for JAMA Surgery, and I'm here today with Dr. Charlotte van Veldhuisen.
Yes, thank you.
And Dr. Marja Boermeester.
Hello, great to be here.
They are both from the University Medical Center and the Department of Surgery at the University of Amsterdam, and today we're talking about their study looking at the long-term outcomes of early surgery versus endoscopy first and painful chronic pancreatitis. This manuscript shares the long-term clinical outcomes from your randomized clinical trial that evaluates endoscopy versus surgery first in patients with chronic painful pancreatitis. And I know that you all had previously published some shorter-term outcomes on this. One of the things that jumped out to me was that there was some pretty careful wording around patients who consented to participate in the current long-term study. Why did you all think that it was important to allow participation in the trial itself without requiring the long-term participation?
So first of all, Amalia, thank you for the introduction and also the invitation for us to be here today. You did a great summary on the study. And indeed, we did in the initial study, we followed the patients for 18 months. But especially in chronic pancreatitis, we know that the disease scores can vary significantly over time. And therefore, we thought that the long-term outcome, especially in these patients treated endoscopically, but also surgically, was very important. So that's why we had to go back to the patients who participated in the initial study to obtain another informed consent for the long-term outcomes. Also because we wanted to evaluate the pain scores, quality of life. And for that, we needed to send questionnaires to the patients. So we needed to obtain consent again.
And obviously, since we hadn't anticipated doing that when we initially started the trial, which was already a very complicated trial to run, and since we've finally finished that after some time, then in the long-term follow-up, we thought this is also interesting to see how these patients are doing in the very, very long term, which is 7-8 years now. So that's the reason.
You mentioned that this was a complex study to conduct, and I, having read through it, can only imagine what that was like. One of the things that I noticed was that within the surgical therapy arm, there were a variety of operations that were performed by the surgeons. And so was the surgical therapy determined entirely by surgeon preference, or was there guidance on this built into the study protocol?
Yes, absolutely. There was a guidance. So we sort of standardized in a few ways to start with both the gastroenterologists and the surgeons involved who were doing the interventions had to have a certain level of expertise and a certain number of cases that they've had done previously. Certainly not novice chronic pancreatitis surgeons or gastroenterologists involved. And we agreed that we would do the extended pancreaticoduodenostomy or a fry procedure depending on the pancreatic head. And large was defined as over 4 centimeters, and that would be in need of a fry procedure. There were a few exceptions, and they were actually deemed necessary by the surgeons at that point. We could agree or disagree, but that's what happened.
It seemed to me that a point of complexity wasn't just the procedural aspect and reaching consensus about that, but also the involvement of multiple centers over almost a decade, really, by the time you did the long-term follow-up, which is a remarkable accomplishment. What did you all find to be the most challenging in the execution of this study?
First of all, we did the study in close collaboration with the Dutch Pancreatitis Study Group, which is a great network in the Netherlands of the Dutch hospitals working together to improve the treatment, but also diagnostic workup for pancreatitis in general. So in this particular study, we collaborated with 30 hospitals, which was challenging on several points. First of all, it was difficult, but also challenging for us to involve gastroenterologists, but also surgeons to be convinced of the study protocol, to obtain consent from patients, but also to inform them saying that both treatment could work, because that's step one, basically. Marja, maybe you can tell a little bit more about that because I think you were closely involved.
Yeah, I've been there from the beginning, being the principal investigator of the ESCAPE trial. That's also why we limited to only a few hospitals that were actually doing the interventions. And within the pancreatitis study group network, which is very used to doing all sorts of trials, as you may know, we published a couple of them. We wanted to get notice of all the patients that were eligible for the trial. And that was the bigger network. So the bigger network needed to refer the patients to the smaller part of the network that was actually the expertise group that was going to do the interventions, as that was also the group that was going to give the information of both of the treatment options. Now, for the bigger part, I think that those, I think 5-6 centers were also receiving the majority of patients anyway. So within that smaller expertise group, it wasn't that complicated because we were all very much convinced of the necessity of this trial, and we were all involved in the design of the protocol, so that was okay. But getting all of the 30 hospitals of the study group joining in and referring their patients at a time that they could still be included, because we wanted early chronic pancreatitis patients who were not on chronic morphine use. So that was a challenge. That was actually the biggest challenge, getting them within our reach before they were beyond the inclusion criteria.
Moving to the findings, I was particularly impressed by the differences in satisfaction and willingness to recommend treatment between the two study groups. Why do you think the early surgery patients were so much more enthusiastic about their management strategy?
Yeah, we thought that was interesting as well. We spoke about it with the team, but we saw that on several points, the pain scores were significantly lower in the patients treated by early surgery. So that could be one of the explanations. But also, as you can see in our data, is that the patients in the early surgery group needed fewer interventions, and making it likely that patients had a lower burden in this disease course and the treatment. So we think that could be an explanation as well. And perhaps patients feel like surgery is a more definite solution for their problem. So they have to undergo the surgery. That's quite intense, and the recovery is hard as well. But once they're over that stage, they feel like they left it behind. So I think that could be an explanation too for this significant difference between the groups.
I totally agree. I think besides having the surgery had a tremendous effect on the pain reduction, usually it was only one operation, whereas the endoscopy first group had multiple interventions. And also on long term, there were many additional interventions. That is a bigger difference. So it was in the years following the actual randomization phase, the endoscopy first group had multiple endoscopic interventions, and then part of them ended in having surgery anyway, which was less effective than having initial surgery. And that's, I think, very important.
Building further on this, in Table 6 in the supplement, which I want to push the readers to because I just found it absolutely intriguing, there was a clear difference between pain in the early surgery versus surgery after initial endoscopy group based on multiple measures that you all used. But there wasn't a substantial difference in quality of life as measured by SF-36 for either the physical or the mental domain. Do you all have any thoughts on why that might be so for this subgroup of patients?
I think you're telling an important outcome that the pain was lower. However, it's interesting that the quality of life isn't going with that. So I think we can think of several reasons why we didn't see the difference back in the quality of life. Firstly, because I think quality of life is affected by multiple factors. So it's not only the pain, but it has several interventions with emotional well-being, for example, social interactions. So first of all, I think pain is not directly leading to a higher quality of life. Also, an explanation could be that we do not know whether we use the right assessment for quality of life, because that's a well-known topic. It's still very difficult to assess that in the right way, especially in these patients. So maybe the quality of life assessment wasn't adequate for these patients.
What was the most surprising finding for you all when you completed your analysis of this portion of the data?
The most surprising, but also I think the most controversial and debate sparking results was the effect of ductal clearance, because the endoscopists were, with the endoscopic procedure, they were doing good in the sense of reduction of pain. But we observed that with the endoscopy group, that those who achieved ductal clearance compared to those who did not, actually there wasn't a difference in outcome, whereas the fact that there was lots of focus of the gastroenterologists on getting ductal clearance, the initial publication of the trial, the reaction from the gastroenterologist was the fact that the endoscopy might not have worked in patient was because in some patients there wasn't adequate ductal clearance, but actually that wasn't the most important factor.
In clinical trials of this nature, I think that one of the most important questions is if it changes practice. Have your findings changed the approach to these patients at your institution?
So I think we can conclude that we actually saw that there is an increase of surgery and I think a more progressive way of treating patients with chronic pancreatitis. But I think that also has to do with the fact that these patients are more often discussed in a multidisciplinary discussion team meeting. So they are probably referred or even seen by a surgeon early in the stage. I think that has a big influence as well. I think in the Netherlands, the whole thought is that we perform surgery earlier. But again, like when we speak about these results in international conferences, we feel like sometimes different countries still are a little bit more reserved with the application of surgery. I think Marja can say something more about it.
Right. Yeah, I think besides our neighbor country, Germany, I think the Netherlands and Germany are far ahead implementing the results of the ESCAPE trial. But at least having a discussion amongst gastroenterologists and surgeons which treatment is best for patients. And the biggest change that we saw is that patients are not under the sole care of gastroenterologists for years and years who've been doing stenting and other kinds of procedures for 5 to 10 years without ever having discussed multidisciplinary or having referred the patients to a surgeon. That definitely has changed, but there is still lots of resistance in other countries to accept the fact that surgery may be a very good solution to begin with. And that's, I think I mentioned briefly before, is that one of the findings is that surgery after having endoscopic treatments first with not enough success on pain reduction, if you then perform surgery, the effect of surgery isn't as good as when you do initial surgical procedure. I think that is something that we now in the Netherlands know very well, and gastroenterologists accept that. So in probably the sequelae of the ESCAPE trial, the ESCAPE 2 trial, if we're going to call it that way, we're going to optimize an endoscopic treatment more in the modern way, where there is intraluminal laser therapy for ductal clearance in the endoscopy group, where there is minimally invasive surgery in the surgery group, where in the ESCAPE trial, many of these patients were operated with an open procedure. So there is this need for updating also in the newer area of treatments. But what is totally accepted is that if you delay surgery, the effect is less than when you start with surgery.
Sounds like it's time for us all to consider a surgery first approach with regard to treating chronic painful pancreatitis. Dr. Van Veldhuisen and Dr. Boermeester, thank you both so much for your time today. I really enjoyed learning more about your study.
Yes, thank you so much.
Thanks for giving us the opportunity to enlighten a bit more details of our study.
I am Amalia Cochran, the web and social media editor for JAMA Surgery, and I've been speaking with Dr. Charlotte Van Veldhuisen and Dr. Marja Boermeester about long-term outcomes of early surgery versus endoscopy first and painful chronic pancreatitis. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Musisi at the JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.